Hello, everybody. Good morning, afternoon, or evening, wherever you're joining from. My name is John. I'm one of the Clinical Problem Solvers Academy members, and I get the privilege of co-discussing a case this morning with Ravi. And Manahil is going to be sharing a case with us, and we have Simi and Eugene doing our scribing and teaching points. So why don't you just take a moment, unmute, and say hi and share something?
Hello, everyone. My name is Eugene. I'm from Ghana, and I'll be scribing today. I'm excited for the case. Yeah, thank you.
Hello everyone. Happy Tuesday, and I'm very excited for Minahil's case and discussion by Dr. Ravi and John, and looking forward to learning a lot and looking forward to the session today.
Hello everyone, I am Minahil. I am an incoming intern at the Corval, and I am presenting the case. It's like basically don't see this patient. Alex, it's the patient of Alec, and I am presenting on his behalf.
Awesome, and thank you, Manal, for presenting that case, and also thanks to Alec and Austin for this case, and also Eugene and Sime for doing teaching points and scribing. And happy Tuesday to everybody. We're approaching the end of May, so hopefully moving into better weather for everybody, and also the incoming interns. Manal, incoming intern to her program, so excited for the new change in your trajectory. So Manal, you want to start with the first aliquot? We'll get going.
Yeah. Okay. So I will start with the chief complaint. It is a 52-year-old male presenting with 6 months of blood in the stool. Patient first noticed a small amount of blood in his stools approximately 6 months ago, accompanied by a gradual 10-pound weight loss during that period. Could not really say if it was bright red, maroon, black, or provide other details on the quality or color. 15 days prior to the presentation, he experienced worsening bleeding, occurring twice daily. Initially, the blood was bright red and larger in volume than usual. About 7 days ago, he began experiencing symptoms of dizziness and fatigue that results in the pre-syncopal episode without the loss of consciousness, and that prompting him to come in. And he also reports intermittent night sweats occurring weekly, but did not have any associated fevers or chills. He had some mild abdominal discomfort for several months, which intensified over the past 2 weeks and peaked on the day of presentation. He had no chest pain, no shortness of breath, no rash, no diarrhea, headache, or other symptoms.
Very interesting. What do you think, John? You want to get started?
Yeah, I can start off a little bit. So just framing the problem, we have a chronic and progressive report of hematochezia. And there was a couple co-symptoms I missed at the very beginning when audio cut out, but it sounds like there was some, it's progressed to where this person's having lightheadedness and feeling like they're going to pass out, suggesting it's reached the point where they're having perhaps symptomatic anemia and more starting to have more severity to this problem. And the presence of mentioning night sweats does make me think, could there be some kind of chronic inflammatory process in the background? So, well, if we're looking for a signature of the chronic inflammation, thinking about the IMA mnemonic, we'll be looking for other things as we go along the way. Is there any, leukocytosis? Does the patient have any fevers? But when we first get this kind of story and we're coming into the emergency department, so our first things are going to be about making sure this patient is okay, making sure that they are stable, and that we're ready to go if this bleeding even progresses and gets worse. It's common. People will come in with relatively mild bleeding, and depending on what's the cause of it, some could be very high risk for having the floodgates open and just having much more, starting more mild and having more severe bleeding. So you have to be ready to resuscitate the person quickly. So that's why always the principle is to make sure you, when you're first assessing the patient, kind of sometimes in tandem when you're getting your history and getting your exam, making sure you have 2 large bore IVs and doing some basic things like getting the patient consented in case they need blood, getting type in screen done while you're doing kind of a rapid triage to see how this patient is doing. Maybe I'll turn it over to see how, Ravi, what are some of your first thoughts? Are you tying in this? I'm seeing now as they update the chat that there's a signature of weight loss. So, the night sweats and weight loss. How are you tying in this perhaps chronic inflammation together with hematochezia to frame your first pass?
Absolutely. Just love how you kind of approached it with framing it and saying, okay, this is the problem. And it's a very common problem that we see in the hospital, and especially for incoming interns, you will see this. And it always creeps me out because I've had many, many patients come in and become very, very unstable, and it becomes very frightening in that situation. So you have to approach this in a very pragmatic sort of a fashion. So number one, the issue is here, this patient's having blood loss or blood into the stools. Number two, there are a few associated features which don't make sense. Usually you won't have pain. So there's some abdominal discomfort, which I'll kind of put a flag in it and then maybe bring it back later. Maybe it will find my differential diagnosis. Third thing, like John had mentioned, immediately while doing the cognitive legwork, trying to figure out where this is, and we try to kind of play that game of anatomically, where is this patient bleeding from? But immediately we need to divert to stabilizing the patient as well, because they can decompensate rapidly. You can see this patient had bleeding for several months, but then it rapidly progressed, and now they're symptomatic in that they're having dizziness, they're having fatigue. So immediately, reflexively, you should start thinking there's going to be some vital sign abnormality. So the first thing in many cases that have been discussed here, we look at the vital signs to think, where is this patient in their journey through GI blood loss? Is this something like a chronic blood loss where you might just glance down at the CBC and just see that there might be a microcytic anemia there, and this patient's been bleeding for quite some time, but chronically, not a massive amount of blood loss. If you see hypertension, tachycardia, you can assume there's been some volume loss, and you immediately have to do what John had walked us through, do all of the measures to start reflexively start treating the patient. And also what's really important is identifying this, although this patient right now may have a normal blood pressure, in about an hour's time, be careful, this patient may not have a normal blood pressure, but recognizing that and then placing them appropriately. So there's different levels within the hospital. There could be an acute floor, there could be telemetry, there could be an intermediate step-down unit, or ICU step-down unit. That usually is where somebody with close, or you need close hemodynamic monitoring, that's where you will put a patient like this, where you really feel that they're going to decompensate rapidly. The abdominal pain, and then John, you brought up a really interesting feature. You just kind of type 1 thinking, the night sweats brought up the issue with inflammation. So inflammation can be one of the many causes of this. Now I'm trying to figure out inflammation. Is it infection? Inflammation, is it a inflammatory state, like maybe infiltration into the gut via cells, intrinsic cells that could cause maybe like a gastroenteritis? Or could this be a malignancy in certain malignancies? Or is that this association with night sweats, lymphomas, and so on? So a lot of people in the chat kind of dove into malignancy as a possible cause. We have the epidemiology, you have an age. We don't have history so far if the patient's had screening colonoscopies. And third, is there family history of certain malignancies, maybe in a younger age? So some data might help us, but immediately the first order of business is to evaluate the patient, resuscitate the patient if necessary, and then start calling people to do the assessment. Definitely would need a colonoscopy, and also then order labs. I'm very interested to see the labs. Although the first CBC doesn't always show a low hemoglobin, it does take some time for it to manifest. Any other thoughts, John, before we move back to the second aliquot?
maybe I'll highlight a couple things people said in the chat. I liked what Hans was saying about thinking about signature of inflammation plus abdominal pain and GI bleeding, considering inflammatory bowel disease and the importance of trying, doing a good family history as you work your way through the case. And like you said about like the CBC and the time course that you see with it, we transfuse for like two main reasons. If you have, everyone's pretty familiar with the hemoglobin less than 7, but say everyone we don't bleed packed red blood cells, we bleed whole blood, and the hemoglobin is a concentration, so it takes some time for fluid shifts to happen. So if somebody is hemodynamically unstable or having large volume blood loss in front of you, you don't wait for that hemoglobin to come down less than 7. So if we get our vitals, this person's dizzy and tachycardic and they're having active bloody bowel movement, we're go ahead and get that person resuscitated with blood. So yeah, I think that I'm ready to move on to next aliquot if you are.
Absolutely. Back to Manal.
Amazing discussion. Going towards the medications, patient is currently not on any medications, no aspirin, no NSAIDs, no significant past medical or surgical history. In family history, his father experienced a year of what seemed to GI bleeding, hysteresis, abdominal distension prior to death, but no formal diagnosis was made as he did not have access to care in his home country. He was originally from a rural area of Guatemala, previously working in the fields, harvesting the crops, now work in the ceramic construction, and he is living in the US from last 5 years. He's a non-smoker, non-alcoholic, no illicit drug use, no non-drug allergies. In the vitals, his temperature is 98.2 Fahrenheit, heart rate was 75, blood pressure was 114/64, respiratory rate was 18, SpO2 was 99% on the room air. He was appearing fatigued and in mild distress. His CVS and pulmonary examination was normal. Abdomen was mildly tender, grossly distended, and there was been panic to percussion, no significant fluid wave. There was mild hepatomegaly, no appreciable splenomegaly. In neuro exam, he was alert and oriented, and he had like few spider angiomas on upper chest, pale conjunctiva, no actress, no rash, no pulmonary arrhythmia, and no peripheral edema. So this is the end of second report.
So wonderful presentation, Minal. I think a lot to unpack here, but I was looking eagerly. When you have a patient like this, you want to at least get history to, if the patient's on any sort of anticoagulation or antiplatelets that could actually fuel the process. So there's nothing here because then you would have to implement reversible measures in this case. So there's no DOAC or anything, although I think the reversal agent for DOAC can be pretty expensive, up to like $30,000, I believe, John, a dose. So we only dose that for severe life-threatening bleeding. But otherwise, warfarin or any other of these antiplatelets, we usually give supportive therapy in this case. And also platelets, since you mentioned something on the exam, I'm very interested if the platelets are also low. So what I'm trying to walk through is any disorder of hemostasis that's making the situation worse. So identifying that and then also treating that at this point, and then doing our due diligence and trying to figure out what's causing the coagulopathy or thrombocytopenia. So I'm sort of jumping ahead, but I'm anticipating. A lot of medicine sometimes is anticipating, taking in what you're saying and then thinking two moves ahead, sort of like a chess game, to be prepared for anything that could surprise us. But just going through the vital signs, what I'll do the vital signs, and then John, you could do the exam. The vital signs, I think the blood pressure was not noticeably low. What was the heart rate again?
It was 75.
75. So fairly relaxed. This is not a patient that's on a beta blocker. Heart rate's not excessively high, so they're not compensating for volume loss. So you can anticipate at this point the blood count's not really, really like at least 50% or below that. Although I was impressed by their symptoms, they're fatigued, they're dizzy, and so on. So they're probably mildly anemic, we could say. And then this would also spur our exam. We would look for conjunctival pallor, palmar crease pallor, other signs. Sometimes you can have, I had a patient the other day with a hemoglobin of 4, and they just look very pale in the cheeks, pale in their hands, pale in their feet. So looking unusually very pale, and that reflexively made me think the hemoglobin was 5 or below in this case. So the blood pressure, usually if you have volume loss, you usually have a narrow pulse pressure with the blood pressure here, but patient's blood pressure was not exhibiting that narrow pulse pressure. So I think the patient is stable at this point, but always be cautious because a patient never is a snapshot in time. They kind of moving through their journey. So they could manifest in the next minute or 5 minutes instability. So you always have to be prepared for that. John, anything come to mind regarding the exam?
Yeah. I like how you brought up one of the exam findings. You brought up like the palmar crease pallor. One of the first episodes I ever watched of Clinical Problem Solvers was Reza talking about there's like a shared teacher that I had too in Pittsburgh, who he was like, he's telling a story about this, looking at this patient's hands, like, Reza, I bet this person's hemoglobin is going to be less than 5.5, and sure enough, ended up being true. But so we'll look for more subtle signs of anemia. And as you talked about the heart rate being normal, like this kind of confirms what we knew from the history in this case, but we don't always know that this has been going on for a long time. If it's been going on for long enough, this person can compensate for it. So I won't be shocked if the anemia depth is pretty significant, but it's just been happening slowly enough that the person's been able to develop some compensation for it. I'll be looking carefully for signs of chronic liver disease. We have this family history of unknown abdominal distension. And if you have a patient with gastrointestinal bleeding and liver diseases, it really changes a lot how you manage the person. You have to think about things like esophageal varices. They're prone to coagulopathy that some of the traditional transfusion strategies aren't super effective for. Like the INR is of somewhat limited value in predicting the risk of bleeding in somebody if they have cirrhosis. You have to think about prophylaxis. So really looking to tease out is there other signs of liver disease. And actually see like and what's adding here is it just to confirm, was there spider angiomas on the chest? Is that okay? Cool. So really worried about the presence of cirrhosis. Even though we don't have a fluid wave, it's kind of a hard test to do unless you have 2 people helping you do it. So if you have the availability of it, getting out the point of care ultrasound to look for ascites, or tapping your way down the abdomen, seeing where it goes from it's tympanic. Eventually, as you work your way down the flank, it's going to become dull. So either make a physical mark or a mental note of where that is, have the person change positions, and tap it out again. And if it's in a new position, that tells you that there's probably some some movable fluid in the peritoneum. But otherwise, if you have like just a diffusely tympanic drum-like abdomen, makes me think of, does this person have distended loops of bowels from an ileus, or hopefully not some kind of obstruction. But yeah, in this hepatomegaly makes me think about, could there be any other even cirrhotic or cirrhotic cause of portal hypertension? Spider angiomas make you think about the hyperestrogenemia that you can see with cirrhosis. And framing this also in the context, circling back a little bit to the social history, a patient from a rural area working in construction, kind of think that, but it, just make me trigger the thought, like, could this person be at risk for other, chronic infections? If they have water exposures, parasitic infections like schistosomiasis or Giardia, or other atypical chronic infections that could lead to the weight loss and bloody bowel movements. So yeah, I think like around where you're predicting the labs, if to try to add weight to the theory about possible cirrhosis, we'll be looking for things like coagulopathy, thrombocytopenia, and Yeah, I think that's I think after this round, I'll pass the mic over.
Sure. What's interesting, we sort of opened the door to cirrhotic liver disease and anticipating. I mean, the spider angiomas could be from many other causes, like you said, hyperestrogenemia, but usually associated with liver cirrhosis. But definitely we want to look at the chemical signal for liver cirrhosis, and then the liver is enlarged. I think it was on mild hepatomegaly, which usually doesn't go with cirrhosis unless there's congestion in the liver. But sort of anticipating or system one thinking cirrhotic liver disease and bleeding. You mentioned the variceal bleeding, so esophageal varices would be one area which we would highly anticipate bleeding emanating from. But also you can get portal hypertension around the stomach, so portal hypertensive gastropathy, or you can have something called watermelon stomach or GAVE happen. So that's gastroantral vascular ectasias, which can also be associated with that as well. So bleeding emanating from any one of those. Now, tying pain to that, I'm still trying to have trouble. So weight loss is non-specific. It could occur with cirrhosis. You have quite a bit of weight loss, muscle atrophy as well, but you may gain with abdominal distension, ascites, and so on. But I'm trying to associate, is the abdominal pain an indication of an emergency? So it's not alarming abdominal pain, like the patient isn't professing like 10 out of 10 abdominal pain. Then you have to wonder, one of the catastrophes associated with cirrhosis. So could there be portal vein thrombosis associated with this? Something to think about. And then you mentioned like all the other things, like if there's obstruction, is there a vascular insufficiency? Something that I thought about earlier on, one of the, when we talk about abdominal pain, we like this whole, the mnemonic that we have. And the mnemonic does signify, one of the features that's signified in that is mesenteric ischemia. So something to also think about. But if I'm trying to take all this data that Manal's given us and try and springboard from that, one of these could point to the cause of this bleeding here. I think we'll continue on with the case. I'll send the mic back to Manal to give some labs.
So I'll provide some labs. CBC, like patient have a WBCS of 8.2 with neutrophil predominance of 81.4%. Hemoglobin was 3.6. MCV was 66.8. RDW was 49.9. Platelets 312. His threat was 0.5. Visual was 14. Sodium was 139. Bicarbs 22. Rest of the electrolytes, glucose, potassium, chloride, calcium, and iron gap was normal. And liver enzymes, AST was raised to 69. ALT was 25. Alkaline phosphatase was raised to 188. And GGT was 144. His total protein was 6. Albumin was low at 3.1. And total bilirubin was 0.7. HIV was negative, lactic acid was normal. Then his ferritin was decreased at 13. Vitamin B12 was normal. Reticulocyte percentage was like increased, that is 3.59. Haptoglobin was low, less than 30. INR was mildly elevated at 1.5. PTT was normal. Fibrinogen was 189. And we also did a peripheral smear which show hypochromia, polychromasia, stomatocytes, anisopoikilocytosis with elliptocytes, target cells. There were teardrops and ovalocytes, and no schistocytes. I will share these labs in chat too.
John, you want to start tackling the labs and I'll follow?
Yeah, sounds good. There's a few of them were just didn't have great audio on my end. I missed a few of the numbers, but we have a pretty significant anemia and signs of iron deficiency that, given the history, or not surprising given this history of reported 6 months of chronic, progressive blood loss. And I love how the team checking HIV. That's one of the things, and it's kind of a universal thing. Anybody with unintentional weight loss, it's good to check because of the weight loss you can see in itself, and thinking about what possible chronic infections we need to be considering in the background too. And some other labs, thanks for sharing them in the chat too, that can be helpful. So we do have low albumin, we have a bit of mildly elevated INR, and low haptoglobin. So not completely a slam dunk first, but we have some things that could go along with corroborating the theory of background cirrhosis. But the platelets are normal. The haptoglobin can be low due to if the liver is cirrhotic and sick and has decreased synthetic function, could be a factor there too. So we don't have signs of clear, there's no schistocytes which is more reassuring. I think looking to make sure there's not signs of clear hemolysis. So I think some of the first, what this person needs in terms of just thinking first steps of management, needs some resuscitation. And while we're working up the cause of what's going on too, I'll comment that during the course of their hospitalization, if they don't declare themselves as having any kind of bacteremia or serious infection, it's a good opportunity to get the person loaded up with intravenous iron. You get some blood, you get some iron back when you give somebody blood transfusions, but it's not nearly enough to correct the lack of iron that you have in your iron stores. So thanks, if I'm continuing to make progress beyond resuscitation, I think I'll still work with the theory of the possibility of cirrhosis, get some abdominal imaging. I think you can pretty quickly get an ultrasound to look for cirrhotic liver, look for any ascites or splenomegaly that could corroborate the protection. Looking at some of the pattern in the labs too. AMK is asking about so the AST to ALT ratio. So that could be, it's kind of the reflex association we have with that is of alcohol use. So certainly having a heart-to-heart about whether the person is drinking more alcohol than they initially let on in the social history. Not everyone wants to share that right up front, but it's not specific to that. AST comes from other places too. We brought up the low haptoglobin hemolysis, so worth still, hemolysis can be tricky to diagnose sometimes. So worth checking LDH, thinking about could the AST coming from red cells breaking down. And there's other like liver diseases that can be associated with AST ALT ratio being high.
I think. Oh, John, you're back. Yeah, you froze there for a second.
Yeah.
Oh, sorry, we missed the last comment that you had because you froze up. Oh, John, can you hear me?
Oh, yeah, I can hear you.
Okay. Okay. We missed the last comment. Yeah, because your screen froze up.
Oh yeah, we're just I was wrapping up with the AMK's comments about the AST ALT, thinking about hemolysis, association with Wilson's disease. If you have a younger person with liver disease, perhaps if there's notes of a psychiatric history to be considered. And
yeah, that's an interesting thought. Yeah, kind of now let's launch into esoteric. When it comes to cirrhosis, two of my favorite sort of probably not good for the patients, but there's two associations with liver disease and anemia, or specifically hemolytic anemia. One is, and they both have to do with, or one of them has to do with heavy alcohol use. One is Zeev syndrome, where we do have this hemolytic anemia, hyperlipidemia, which can occur. And I think when you abstain from alcohol use, the Zeev syndrome resolves. Another one is when you have advanced cirrhosis, you have spur cell anemias. I didn't see spur cells listed in the peripheral smear. We see more actually normal cells, target cells and teardrop cells. So no spur cells, which would clue us into spur cell anemia, which usually is associated with advanced liver cirrhosis. And usually the cause of that, although that one is non-hemolytic, the first one, Zeus is hemolytic. And with that, you do get jaundice and abdominal pain. But I know the treatment for spur cell anemia would be liver transplant, should help with that, which is the only curative option in that case. But then treading back to what we're dealing with here, you're right. I like that. Yeah, ferritin is low, but we're dealing with a cirrhotic liver. So I wonder how useful. I haven't had experience. So the liver will produce ferritin. It's an acute phase reactant. And we already have identified this patient has inflammation. So it should be higher as an acute phase reactant. But here it's low. So maybe it's not produced by the liver, but whatever level it's producing should be maybe high or normal, but this is a lot lower. And so this could signify, yes, there could be true iron deficiency, although it's difficult. Maybe you could then pivot over to one of the other parameters. One is % iron saturation, if that's low, or then you can move on to the soluble transferrin receptor marker, which is another one, which is kind of more specialized, and a lot of labs or a lot of institutions don't have access to that, but that's another one that's not influenced by inflammation. But here I think we have a multi-layered anemia. So could there be iron deficiency layered on top of cirrhosis, which usually manifests with a macrocytic anemia, and then you have bleeding causing microcytic anemia, maybe normocytic anemia, and then we have anemia of chronic inflammation. So we have a hodgepodge of different anemias all packed together, and so all causing this this presentation here. And then just quickly looking at the platelets, you know what's interesting with cirrhosis, usually platelets can be a good signal, although it's not definite. It's not pathognomonic for cirrhosis, but usually I would look for, hey, the platelet level will be low in chronic cirrhosis. So they are also a marker of inflammation. They can act as an acute phase reactant. So I don't know how much we can sort of invest into this, but I'm right there with you in regards to this, that there is a low albumin. The INR, I don't see. Oh, INR is 1.5, so not terribly high. Fibrinogen is normal. So at this point, I'm just wondering, yeah, I have to then see what Manal has in store for us. So it's just exploring this Zeev syndrome and so on, and spur cell anemia. I don't think we're going to venture into those areas, but I'll see what Manal has in store for us.
Wonderful discussion. We did the EGD, and that showed medium circumferential grade 2 esophageal varices with recent bleeding, and 3 bands were placed successfully. There was also mild portal hypertensive gastropathy, but no gastric varices. In colonoscopy, we find like external and internal medium hemorrhoids with no active bleeding. Rectum was normal, no rectal varices. Patient hemoglobin improved and stabilized following the EGD and transfusion. He did not have any further bleeding after this. We also did the abdominal ultrasound with Doppler, and it came out like patent. There was cirrhotic liver morphology with sequelae of portal hypertension, including the trace ascites. And we find like an ill-defined 7.9 centimeter mass in the right hepatic lobe. But they recommended CT for further characterization. And we also found like blue sludge, gallbladder wall thickening without cholecystitis. This will be the end of this.
Wow, what do you think, John?
Yeah, so sounds like we're getting more corroboration of some of the working theory of cirrhosis is now confirmed with some manifestations of that. Portal hypertensive gastropathy that can ooze, the varices. It doesn't sound like there was perhaps not a frank, devastating variceal bleed, but were present and were significant enough that the endoscopist banded them. Are you able to hear me? I just see a comment now that says can't really hear. Are you able to hear? Give me a nod if you're able to hear me. Okay. Okay, good. All right. And so we have this presence of some ascites when you have GI bleeding. So just throwing back to a little bit about some of the management we would be doing along the way too, is if you have somebody with either, stigmata of liver disease or some suspicion of cirrhosis, you don't know their variceal status, and when they're coming in, especially, significant, no one's going to fault you for starting an octreotide infusion to try to vasoconstrict and control the bleeding along with the pantoprazole and the standard things that we do. And whenever you have ascites and GI bleeding, it's one of the indications to give somebody prophylaxis for SBP, so you can give them antibiotics as well. So now that we've kind of found that we have these problems, manifestations related to the portal hypertension and the bleeding, it's still uncertain about why does this person have, this sounds like this cirrhosis. We always think about alcohol, chronic, hepatitis C or B infection, and then there's but we don't. So of course, I didn't see that we had testing for those yet. But then thinking through the genetic, autoimmune, metabolic causes of cirrhosis, certainly worth being considering in somebody who say doesn't test positive for one of the infections that can do it, don't have a strong alcohol history. Worth doing the full metabolic workup for things like, I don't test for these things in everybody that comes with cirrhosis, especially if you have a history of drinking. But and thinking about I didn't hear like obesity in the past medical history for like the metabolic syndrome associated, another common cause. So thinking about the more uncommon things too, Wilson's, antitrypsin, and et cetera. So probably send off the full panel. And if you don't have a clear answer from the blood work, once the patient is stabilized, not bleeding, considering if there's a role for liver biopsy to see why is the liver sick, and perhaps that's now the nature of the question that we're asking. And also need to hopefully to characterize this liver mass. When you have a liver mass in a patient with cirrhosis, the first thing we worry about is hepatocellular carcinoma. So checking AFB and doing the either MRI or CT, triphasic CT, to better characterize. It's one of the answers that they can be pretty confident about the diagnosis based on imaging characteristics when you get the triple phase CT or the correct MRI study. So yeah, I think I've shifted almost from kind of thinking about why is we found the bleeding, the portal hypertension, cirrhosis, but why? And this is kind of the nature of what we're getting to now. So what do you think?
Yeah, absolutely. You did a very nice outline of possible causes as to see why this patient's got liver cirrhosis. We don't have even a history of heavy alcohol use. We tend to ask, I think I've noticed a lot of times people ask or prematurely just associate liver cirrhosis with alcohol use, but there's many other causes. And sometimes we have to step back and not repeatedly just ask patients, are you drinking alcohol heavily? Because there's many other causes. We've had metabolic associated liver disease as well. So the mast cell D transform into liver cirrhosis, certain number of that. And we're seeing more and more of metabolic associated liver disease transforming into cirrhosis, or a large amount of the patient population having this, and they're not drinking alcohol. So we need to be non-stigmatizing. And I've even seen on records patients with cirrhosis not drinking and alcohol use being put on the record as well. So we got to be careful, keep our minds open, go through all the potential causes that John had listed, as not everybody's probably has cirrhosis secondary to alcoholic liver disease or alcoholism. Any other thoughts, John?
What do you think? Like, I'm kind of like circling back to this history of the abdominal distension in the father without a formal diagnosis made. Did his father also have decompensated liver disease with cirrhosis? Can't assume, but it's worth thinking about that. And like, what causes of cirrhosis could be associated with a family history? So certainly, testing for autoimmune or things like our ferritin's low, so things like hemochromatosis wouldn't be high on my list. But thinking like what causes of cirrhosis could have a family history is tickling my brain a little bit here too.
Yeah, well, you know what's interesting as well? When you have infiltrative, so there is a signature within the labs usually, but not everything's not certain, right? So ALP will be greater as infiltrative or pathology moves into the liver, causes biliary duct disturbance, causing upregulation of ALP in this case. We're not seeing that here. So I would anticipate ALP being greater, and that indicates infiltration or tumor evolving within the parenchyma of the liver. I'm not seeing that here, but does that rule this out? You can never say never. But if I did see that, I really would have my antennas up for maybe infiltrative conditions, but it's not completely ruled out. I think the chat has been mentioning a few things. Yes, infiltrative liver diseases, and there's many kind of different things. Lymphomas can infiltrate in there. Metastasis can infiltrate in there. Granulomatous disease, like you mentioned, we've had cases of TB, sarcoidosis, and so on. Histoplasmosis infiltrate into the liver. So, but right now that will be lower on my differential because I'm not seeing that, but it doesn't completely rule it out.
Not that I have a high suspicion for this patient. I just reminded me of some of the discussion reminded me of a case where there was a patient where they were presumed as cirrhosis based on the imaging, and there was stigma, there was signs of portal hypertension too, but it really was like the liver was just unfortunately just like overtaken with metastatic disease from an underlying gastrointestinal malignancy, like this pseudo cirrhosis, which also caused some of the same phenomena. But yeah, I'm thinking in this case, we don't have a clear-cut answer with some of the next passive labs, just starting to think ahead about the, tissue may be the issue to get the answer. So we shall see.
Great discussion. We did the hepatitis panel that came out negative. Then we did ANA, ASMA, AMA, ALKM that all were negative. IgG were within normal limit, A180 and sevoflurane was known. Basically, we did the whole workup for cirrhosis to determine the etiology and all came back negative. We again confirmed with the patient and his family for the pause use, but he didn't have any historical pause use. His A1C was normal. His total cholesterol was 65.8. HDL was 99.5. LDL was 35. Then we ordered CT abdomen and pelvis that showed cirrhotic liver morphology with sequelae of portal hypertension, including a dilated main portal vein, splenomegaly, and small volume ascites. There were enlarged abdominal lymph nodes, anterior diaphragmatic lymph node concerning for metastatic lymphadenopathy, and there was 9 centimeter hypoenhancing mass in the right hepatic dome. AFP came back as 5546, that was like markedly elevated. We did a paracentesis that shows the SAG is greater than 1.1. Total fluid protein was less than 2, and there was no evidence of SVP. And this is the end of this argument.
Yeah, so again, I want to echo what John mentioned. Like imaging doesn't always. We've had a number of cases on CPS where the image may indicate cirrhotic nodular liver, but it doesn't always indicate. It could be a false positive for cirrhosis. But I think there is something that could be akin to a pivotal point, the lymphadenopathy. And so you wonder, again, now revisiting granulomatous disease, could there be something in those lymph nodes? Then also lymphoma, what kind of malignancy of the lymph nodes can occur? Lymphomas can be positive of that. So I wonder, when you think about lymphomas, you have more the non-Hodgkin's type, which could be, Hodgkin's would be in a younger person. They're more, contiguous in their spread. But here, they're all over, so diffuse. So you wonder about diffuse large cell B-cell lymphoma can cause something like this, kind of almost like a mimic of many certain things. So I'm definitely I'm interested in this lymphadenopathy. Maybe it warrants a biopsy to see what's going on, and also bone marrow, is it involved with all of these different cells? You start getting perturbance of all these cells because of infiltration. So that's kind of where I'm thinking at this point. What do you think, John?
Yeah, like some of the more common things that we're familiar with have been ruled out in this. It's highly concerning for HCC as the cause of the mass, which I usually kind of think of that as kind of a manifestation of a decompensation of cirrhosis leading to that. But still thinking about what was the cause of the cirrhosis. In the background, we have this weight loss, lymphadenopathy. Is this related to the which could be from the HCC, but what caused the cirrhosis the presumed cirrhosis to begin with? So maybe it's just, I think I would be advocating for getting tissue at this point. I wasn't being pulled super heavily to the bone marrow. I know we had like the teardrop cells on the smear, which can be a sign of possibly of something infiltrating the marrow, and these like teardrops cells being squeezed out. The white cells and the platelets are normal, and one cell line down out of 3, but so it probably wouldn't be my starting place to think about getting tissue from. So yeah, I'm still not certain of the diagnosis, but I think might make progress. I'd be advocating for for getting tissue, and still by this family history, there's some connection with what happened to this patient's father connected here. Still thinking about that.
Yeah, there's one lab, I think Manal kind of cut out there, but I just saw on the whiteboard, the alpha fetoprotein being high can also be a signal for HCC. So just sort of rolling back, considering other causes, maybe this is just HCC with an expression of alpha fetoprotein, could make pretest probability pretty high with the association. So something to sort of chew on while we're trying to contemplate the diagnosis here.
Yeah, like usually, like if you have, say, somebody with like alcohol use disorder or metabolic syndrome and cirrhosis, you have characteristic imaging findings, and you have the alpha fetoprotein, you wouldn't ordinarily need tissue to confirm a diagnosis. So I'm still kind of wondering what was the underlying root cause of this to begin with. I feel like I still don't have a handle on that. If the HCC was in the setting of the cirrhosis, and perhaps for all the things he's experienced, like the weight loss, the bleeding, these things, but what's the proximal cause of all this is still bugging me.
Back to you, Manal.
So after that, we did the MRI liver that shows cirrhotic hepatic morphology. There was T2 hyperintensity and peripheral restricted diffusion with mild intrahepatic ductal dilatation. So this could represent a mass forming the intrahepatic cholangiocarcinoma, and they recommended further evaluation with biopsy. There were enlarged lymph nodes, including the porta hepatis, subdiaphragmatic, and periaortic nodes. And there was like a sequelae of a portal hypertension. Then we ordered the CT chest with contrast that show metastatic mediastinal, left intrathoracic, and right cardiophrenic lymphadenopathy. There was like no pulmonary nodule or mass. Per oncology request, he underwent a biopsy of the liver mass to confirm HCC versus cholangiocarcinoma, and biopsy confirmed the hepatocellular carcinoma. Ascitic fluid cytology also returned with malignant cells consistent with the HCC.
Oh wow, John. So it was HCC. We were kind of doing this dance around HCC to make sure we don't forget other potential causes, but at the core of this, it was HCC, and the signal was pretty much screaming HCC. It was interesting. A few weeks ago, I think Ethan presented a case in a younger patient with liver mass, and it was in a younger male. You would have to wonder about germ cell tumors to sort of bring that space learning back, something to consider. That was a yolk sac tumor. which was interesting. But in this case, it's a middle-aged person with cirrhosis not being previously diagnosed and developing consequences of that. So thank you, Manal. A great case. Definitely we'll be thinking about it today. Any reflections, John, on this case?
Yeah, lots of good learning along the way here. Like, what did they think? What did the specialists think, though, was the cause of the cirrhosis itself, though? That's the one thing that's just kind of bugging me.
I want to share the reflections. Okay, so like we didn't find a clear etiology for cirrhosis, but patient was living most of his life in Guatemala at a young age. So there was like negative secondary workup, so possibly cirrhosis in his father. We wondered if exposure to the aflatoxin B1 could have been the cause, given its association with cirrhosis and HCC. They like basically consume maize, that particularly in the form of tortillas, and that is a significant source of AFP1 exposure. High tortilla consumption correlation with increased alpha beta 1 albumin levels. Genomic analysis of glutamelin HCC cases reveal the mutation in TP53 and other genes that indicate that AFP contributes to the liver carcinogenesis in this population. And given the low prevalence of Hep B and C infection like Guatemala, AFP1 is considered a major etiological factor for HCC in this region. But we unfortunately did not have access to any confirmatory testing to investigate this further. So that's are my reflections on the case.
Wow. I think that helps kind of just important to frame my thinking when I hear about suspected family history. I think I got caught up thinking about things with a genetic link to it, like direct hereditary things or autoimmune diseases that may run in a family. But I think I neglected to think about shared exposures that they may have had from their background. So that's probably my take home from one of my big take homes from the case today. So thanks so much for sharing those thoughts.
Thank you, and we'll have Seema take it away with teaching points.
Thank you, Manahil, for sharing such an interesting case and loved the discussion and got to learn so much. And thank you, Jean, for scribing. And here I have a brief summary of all the wonderful teaching points we covered today. So we had this patient who presented with hematochezia and dizziness. And when the patient had hematochezia and dizziness, we were wondering that whether the patient has anemia. And we considered that hemodynamic monitoring would be very important in such cases. Then the patient also had night sweats and weight loss. So we were also wondering about the inflammatory component. And for this, we can always think about the IMA mnemonic that stands for infection, malignancy, autoimmune disease, drugs, and everything else. Then on further examination and vitals, we saw that this patient had spiderangiomas, and we were wondering whether they were due to hyperestrogenic state or due to cirrhosis. And we discussed that whenever a person has bleeding, we should check for pallor by checking conjunctival pallor, and we can also look for palmar crease pallor to see for anemia. And then as for, we touch bases on Zeev syndrome, which is characterized by hemolytic anemia, hypolipidemia, and jaundice. And when this patient had ascites and GI bleed, we discussed that it is important to give octreotide to these patients and SPP prophylaxis. And we discussed what can be the cause of cirrhosis, whether it is genetic or any malignancy, autoimmune causes, as well as some diseases infiltrate the liver, such as TB and other gallimimus diseases. And at the end, we had elevated alkaline alpha-fetoprotein level, and the diagnosis of hepatocellular carcinoma was made. But we also discussed that it is important to keep multiple risk factors and multiple exposures in mind as well. So great learning and really interesting case. Thank you so much.
Thank you, Seema. Wonderful teaching points again. All right. Thank you, John, for co-discussing. Just appreciate all the wonderful teaching that you brought to this case today, and wonderful job again, Manal, for presenting such a rich case and excellent presentation. Again, thank you, everybody. Take care. Happy Tuesday. See you tomorrow. Bye.